everyone. My name is Ty. I'm a project management assistant at ICPSR. I work on the Health and Medical Care Archive, or HMCA, which is the dedicated archive of the Robert Wood Johnson Foundation. And today we're sponsoring this webinar. HMCA has over 250 free data sets on healthcare, health attitudes and opinions, and series data for you all to explore. I'm going to post a link of our webpage for you all to have in this chat here. Okay, and two of our series data are the profile of local health departments and the forces of change. These surveys are carried out by the National Association of County and City Health Departments, or the National Association of County and City Health Officials, or NACCHO. Today, we have Dr. Tim McCall and Margaret Cunningham from NACCHO to talk about these surveys in light of the COVID-19 pandemic. Tim McCall is the Director of Research at NACCHO and a social scientist with 12 years of experience leading experimental and survey research analytics. His research interests include workforce issues, equity, and well-being. Margaret Cunningham is a senior research and evaluation specialist with NACCHO. Her experience in the public health workforce includes 3 years with the immunization program at the New Mexico Department of Health and 5 years as an infectious disease epidemiologist with the state of Oregon. She is also a registered nurse who has worked in family practice and infectious disease specialty settings. And before I hand over the mic to our hosts today, I want to let the audience know that this webinar will be recorded and the recording will be made publicly available via the ICPSR YouTube page. Audience questions are welcome and may be submitted during the presentation through the Q&A function in Zoom. We will cover these questions at the end of the presentation. A live transcript is available. To show or hide that transcript, click the up arrow on the live transcript button or the closed caption button. Please note that for those viewing on a phone or tablet, the Zoom app currently highlights only the active speaker. The live transcript will still be available. You may need to scroll to the left or right to see the presenter or the presentation. For privacy, all participants are in listen-only mode, with microphones muted, and chat between participants is unavailable. Thank you so much for attending. Tim and Margaret, the floor is yours.
Great, thank you. Margaret, are our slides displaying? Awesome, thanks so much. Thank you everyone for joining us today. We're excited to present data from 2 of our most recent surveys on the local health department infrastructure and practice in the United States. Just a little bit more information about NACCHO. The National Association of County and City Health Officials is a member organization for local health officials and the health departments, and we represent nearly 3,000 local health departments in the country. The studies that we're going to be discussing today were designed, fielded, and analyzed by NACCHO's research and evaluation teams, and were funded by CDC as well as Robert Wood Johnson Foundation. Just for everyone's information, we do make these data sets publicly available through our website as well as through ICPSR. So today we'll be highlighting select findings from 2 of those surveys. And we want to bring awareness to some of the types of data that we have in these surveys, as well as highlight some national level findings about local public health throughout the health departments in our country. You can go to the next slide, Margaret. So the first study that we're going to talk about today is our 2019 national profile of local health departments, which we, because of the ongoing COVID-19 pandemic, this has become a great source of information for us to reference to understand what the local public health landscape looked like and was experiencing before the onset of the COVID-19 pandemic. Next slide, please. So just to give a little bit of study background about our 2019 national profile, it is designed to develop a comprehensive and accurate description of local public health infrastructure and practice. And our first profile study was conducted in 1989. It's conducted every 3 years and is fielded to all local health departments for surveying purposes. And today, like I mentioned, we're going to discuss the 2019 administration, which was our 9th administration of this longitudinal study. I should mention that the 2022 National Profile of Local Health Department is currently undergoing analysis. We fielded that in the summer of 2022 throughout the fall, and we are hoping to have those results ready this summer for public consumption. Next slide. For the 2019 National Profile Study, we contacted 2,459 local health departments to include them in our study population, and they represented local health departments across the United States. You might hear me using the term LHDs throughout this presentation, just to simplify the long phrase of local health departments that you'll hear from us a lot. So the study was distributed in such a way that not all LHDs received every question in the survey. All LHDs did receive a core set of the questions, and a random sample of LHDs across different jurisdiction sizes may have received an additional 1 or 2 modules to ensure that we were able to collect vital information without overburdening our already busy local health departments. So the 2019 profile was administered over around a 6-month period from March to August of 2019 and achieved a 61% response rate. To adjust our estimates for oversampling as well as non-response, which we document in our public report as well as the technical documentation, we computed national statistics using survey weights via post-stratification based on the size of the population served, or you may hear us mentioning in this presentation, size of population served as jurisdiction size. And as I mentioned, you can get even more detailed information on our methods in that public report and technical documentation. Next slide. Explaining a little bit further, now that I've briefly talked about the methods of this study, you'll see that local health departments received questions from the core set of the core section of the survey, and this included topics such as jurisdiction and governance, workforce, staffing changes, funding and budget, and others. An additional sample of LHDs also received questions in the form of Module 1 on topics such as academic interactions, partnerships, emergency preparedness, and a couple of other topics as well. And then finally, another sample received an additional question module we call Module 2 on topics like community health assessment and planning, quality improvement, public health informatics, and some other topics. Next slide, Margaret. So diving down and getting into some of our high-level national findings, now that we've given a little bit of context about the longitudinal nature of the profile study, the information that we're collecting, and some of the methods that we're using, we want to highlight that Profile has workforce and finance data for local public health, and these data are able to be used to calculate trends over time. A lot of the findings that we're discussing today, NACCHO is really the only source, the only comprehensive source of some of this information about our local health departments. And we understand from 2019 profile data that LHDs came into the pandemic at a workforce and financial deficit, which I think is going to become clearer on this slide as well as some of our following slides. But specifically about workforce, in the 12 years preceding the COVID-19 pandemic, our local public health workforce consistently shrank, both in terms of total employees, but also in terms of full-time equivalents. In 2008, the estimated size of the LHD workforce was around 184,000 people, with over 162,000 full-time equivalents or FTEs, and that's in comparison to just 153,000 total estimated employees, 136,000 total FTEs 11 years later in the year 2019 when we collected this data. Next slide. When we're looking at our FTEs or our full-time equivalents specifically, when we standardize the numbers in order to represent the number of FTEs per 10,000 people in a jurisdiction served, again, we see that the local public health workforce per capita has been declining from 2008 to 2019 prior to the pandemic. And this rate differs based on jurisdiction size. So small LHDs decreased from 6.8 to 6.2 FTEs per 10,000 people. Medium-sized LHDs, which are around 50,000 to up to 500,000 people served, they decreased from 5.2 to 4.3 FTEs per 10,000 people served. And our large LHDs greater than 500,000 people served decreased from 4.9 to 3.6 FTEs per 10,000 people served over that 11-year period that we've been talking about. Next slide. So in addition to the size of the local public health workforce decreasing over time prior to the pandemic, the mean per capita expenditures or average expenditures at the LHD level by person decreased over that period of time as well. The median per capita expenditures also slightly decreased. So as we're seeing over time a reduction in the workforce and FTEs, we're also seeing reduction in the FTEs per capita, and we're seeing the mean and median per capita expenditures by local public health departments decreasing going into our pandemic. Next slide, please. We do see, perhaps in retrospect, some positive news considering the onset of the COVID-19 pandemic in 2020 that when we're looking at year-over-year budget changes, we see that decreases in budget from the previous fiscal year were more common than increases in most of the last 12 years. However, that trend started to reverse slightly before the COVID-19 pandemic. So in 2018 as well as 2019, budgets increased in comparison to the previous fiscal year, and this was more common than it wasn't among local public health departments. I'll hand it over to you, Margaret.
Thanks, Tim. So while Tim mentioned that local health departments came into the pandemic at a workforce deficit and a financial deficit, at the same time, they were expanding their capacity for a lot of services and programs prior to the pandemic. Emergency preparedness, as many of you know, is a part of public health work that has been growing and has seen much more attention over the last decade. So in the 2019 profile, prior to the pandemic, we asked our respondents how much emergency preparedness budgets had changed. And we found that 62% of LHDs reported the same budget as the previous year. And 19% noted a lower budget. But when we're looking at the breakdowns by the size of the population served, we saw that 71% of the medium and large sized LHDs said that they had the same budget, while that was only true for 55% of the small local health departments. Breaking that down by region, we saw that Western and Midwestern health departments were more commonly reporting lower emergency preparedness budgets than their counterparts in the Northeast and the Southeast. In terms of emergency preparedness work in response to all hazards events, more local health departments reported responding to foodborne outbreaks and other non-influenza disease outbreaks in 2019 than they had in the 2013 survey cycle. Fewer responses rather were reported for natural disasters in 2019 than in 2013. And this trend follows for most of the other all hazards events that we asked about, including chemical spills and potential radiation exposures and exposures to biological agents. We did not ask about opioid-related all hazards events in 2013, but in 2019, we did see 10% of respondents say that that was something that came up in emergency preparedness. So as far as other services go, a larger proportion of local health departments expanded rather than reduced their clinical services and their population-based prevention services in fiscal year 2019 compared to the prior year. Again, we asked about changes in services year over year. So over 20% of agencies who responded to this survey said that they'd increased their immunization services and their diabetes screening services. And almost that many expanded their maternal and child health services and communicable disease control activities. And in all categories, we saw expansion more frequently than we saw reduction. And that difference was greater for the clinical services. Interestingly, about 39% of respondents said they'd expanded their tobacco, alcohol, and other drug prevention services compared to only 5% of local health departments who had reduced those services. We ask about there's two sections in the profile questionnaire that ask about changes in programs and services. One asks the respondents to indicate whether or not they provide that service, regardless of scope. And then a second question asks them to indicate how service areas have changed year to year, whether they've expanded, increased, reduced, or didn't change. So that is something that is trackable longitudinally with our data and is kind of interesting to follow in the pre-pandemic setting. Now, in the core survey section on public health policy, we asked about engagement by local health departments in assuring access to healthcare services through activities like needs assessment, direct clinical service provision, or participating in partnerships or networks of referral to increase access to care. And we learned that the proportion of LHDs that are doing that kind of work, either assuring access through advocacy or referrals or direct provision, especially in behavioral healthcare services, increased a great deal from 40% in 2010 to 62% in 2019. And that was a bigger increase than we saw in medical services and dental services. So as all of you probably know, public health informatics is a growing field that is changing rapidly. And as we well know, in 2022 was critical in informing the pandemic response. And when we look at all of the LHDs who responded to our survey in 2019, the most common system, informatics system that they reported implementing were IISs or immunization information systems. And then after that was disease reporting systems. We can see here that implementing these systems varied by the size of the local health department, with more implementation among those large health departments, to no one's surprise. And this was the scene that was set for information readiness before the pandemic. And looking over time, we can also see that the LHD's use of electronic health records has gone up a great deal from 2008 to 2019, and that historically immunization registry use has been high and also increased over that period. And I'll send it back to Tim.
Thanks, Margaret. So as we've discussed so far about our 2019 national profile results, it's really become a great source of information of looking back and seeing what the context looked like prior to COVID-19. It showed us that prior to the pandemic, LHD's capacity were decreasing while they were working to address more issues within the public health space. Next, we're going to spend some time and we're going to move on to our 2020 Forces of Change study for a brief overview of some of the key findings, which will give us some context from what was going on in the middle of the first year of the COVID-19 pandemic into the second year of the COVID-19 pandemic. Next slide. So the Forces of Change study is another major survey that NACCHO conducts periodically, and it's generally fielded in years that the national profile is not fielded in. So the purpose of this study is to develop a comprehensive and accurate description of LHD infrastructure and practice, just as with the national profile, but also to assess changes in LHD capacity that are driven by public health trends, such as the COVID-19 pandemic. So it would probably come as no surprise to anyone that in 2020, the major focus of our Forces of Change survey was related to the COVID-19 pandemic. Initially and historically, the Forces of Change survey measured the impact of the Great Recession on LHD budget, staffing, and programs. But in 2014, NACCHO expanded the survey to address these broader social, political, and economic impacts on local public health that, such as the opioid epidemic, or again in 2020, focusing on the COVID-19 pandemic in particular. Not discussed today, however, is the forthcoming 2023 Forces of Change data, just for everyone to understand what some of the trends we're currently preparing to look at are. It's going to be administered through in April through June of this year, and we'll be having a focus on the standard economic surveillance and staffing, but also a particular focus on infectious disease surveillance and analytics, data modernization, and several other topics. Next slide, Margaret. So similar to our profile study, our Forces of Change study follows a similar format. It was in 2020 administered to 2,392 LHDs, representing LHDs across the United States. And it was administered in a way similar to profile, where not all LHDs received every question that we were surveying about. Some LHDs, or I should say all LHDs, did receive a core set of questions and a random stratified sample of LHDs from different jurisdiction sizes received an additional module in order to ensure that we were able to collect that vital information without overburdening our LHDs once again. The 2020 study was administered over a larger period of time. It was over a 5-month period of time from October of 2020 to March of 2021. And it achieved probably does not come as a surprise to most of us who are in public health. There was a 25% response rate given the rapid response that everyone was having to undertake during this time. To adjust the estimates for oversampling as well as non-response, just like in the profile study, we computed our national statistics using survey weights that were based on that size of population or jurisdiction size. And once again, we provide complete methods and technical documentation, which is available on our website, on our public report. Next slide, Margaret. So based on what we've talked about already, with some of the data that we've highlighted from the 2019 profile, following years of chronic under-resourcing, the pandemic stretched the local public health infrastructure to its limits. So in this unprecedented situation, 3 in 10 LHDs reported not hiring any employees specifically to meet the needs of their LHD's COVID-19 response. 1 in 3 hired between 1 and 4 employees. So based on this, we know that less than half of LHDs nationwide were able to hire more than 4 employees specifically to meet the needs of the COVID-19 response. We'll move on. So given the nature of the pandemic and what we may expect given the challenges with funding and staffing, and the way that it was needed to respond to COVID-19. The most common types of employees hired specifically for the COVID-19 response were contact tracers, which more than 4 in 10 LHDs hired, who did hire, reported hiring. Public information officers were hired by over 1 in 3, and disease investigators or disease intervention specialists were hired by more than 1 in 4 LHDs. 3 in 10 LHDs who did hire, report that they hired staff, reported that some or all of those hires were temporary staff, and almost a quarter reported that some or all of these hires were contract staff. Only 2% of the LHDs that we've collected data from reported deploying volunteers specifically to meet the needs of an LHD's COVID-19 response. We do see, this should be familiar from earlier in our presentation, that year-over-year budget changes are showing us that once again, while funding was decreasing in the last 9 of the last 12 years, we did see that going into the COVID-19 pandemic, more LHDs were reporting higher budgets in the 2 years previous to COVID-19 than those who reported lower budgets. And more than half of LHDs, when we are inquiring about the money or expenditures that are spent for COVID-19 in 2020, more than half of them did not report those total expenditures, but of the half of LHDs who were able to give us data on the expenditures in 2020 related to COVID, the median expenditures were somewhere between $100,000 to $250,000 in order to respond to the pandemic. So another piece of this survey, we asked for LHDs to indicate from a variety of categories what they used COVID-19 supplemental or emergency funding for. And just to note, LHDs were permitted to select multiple different categories on this, since often those supplemental or emergency funds were going towards multiple different efforts or initiatives. Almost 8 in 10 LHDs reported using supplemental or emergency funds in order to obtain personal protective equipment or PPE supplies, and almost 2 in 3 reported using it to hire additional personnel to perform contact tracing. 3 in 5 were using these funds in order to obtain other non-PPE supplies that were relevant for responding to the COVID-19 pandemic. And I'll hand it back to you, Margaret. Oh, you're muted.
Of course. Sorry, Al. Thanks, Tim. Following the public health emergency declaration in 2020, most local health departments mobilized very quickly with what was available to them, resource-wise and staff-wise. So among the LHDs who responded to the Forces of Change survey, about 80%, or 4 in 5, responded that they had reassigned staff from other programs to support the pandemic response. So the most commonly reassigned employees were those from environmental health, but also a lot of staff from maternal and child health, chronic disease prevention, and STI and HIV services were also reassigned to help support the response. So with so many staff reassigned and doing other work, a lot of local health departments, a majority, reduced some of their clinical services and their population-based preventive services, especially screening for chronic diseases and other preventive services. Not surprisingly, about 2/3 of local health departments did report that their epi and surveillance activities expanded, while 71% said that they increased their emergency preparedness and response work. So this graphic here shows departments who shows the response of the departments who said that they increased or decreased, but those who said that they didn't know, which could be fairly common as the funding was so fluid, were excluded from this analysis. So we also asked about barriers and barriers to a good response at the local level. And the barrier that was most frequently reported was workforce capacity, amount of staff. So over 3 in 4 LHDs reported that they did not have enough staff to respond adequately. Not surprising, given the previous information about hiring. So over half of the agencies who responded did say that inconsistencies in guidance from state and federal authorities were a big barrier in having an appropriate response. Now, at the time that we administered this survey, most local health jurisdictions had a pandemic response in place, had a pandemic response plan in place that had either been recently developed or had been updated in the past 5 years. 13% said that they were not using a pandemic response plan at all, but they were using a more general all hazards plan and adapted that for their pandemic response. So about 3/4 of the respondents indicated that they worked on focused initiatives to address public health issues that the pandemic had exacerbated. Nearly half of the respondents told us that they had prioritized work that was addressing behavioral health concerns and mental health issues. And about 45% of respondents said that they were prioritizing efforts to address vaccine hesitancy in their communities. Back to you, Tim.
You're also.
Sorry about that. Thanks, Margaret. As we've highlighted in this section, highlighting the findings from the 2020 Forces of Change survey, LHDs experienced several challenges in their pandemic response in their continued limitations to the workforce and financial capacity. This included suspending foundational public health services in order to reallocate capacity for the critical frontline response, as we found that 4 in 5 LHDs were having to reassign staff to 2 different areas in order to respond to the COVID-19 pandemic, all while facing unprecedented levels of harassment related to their role in public health. So we've not been able to dive down deep into that, but those are some additional findings that we collected in our 2020 Forces of Change survey. So infrastructure challenges, as well as personal challenges from the public and political leaders as well, due to their role in public health. I'd like to give a brief overview of our products that are available related to the analyses and the data that were shared in this conversation today, so that you can read all about these high-level findings, as well as some of the tidbits that I just mentioned and all of the data that we haven't had time to share today. Our 2019 national profile has a full report available at NACCHO.org/profile, in addition to a couple of research briefs, one on workforce and finance trends and one on emergency preparedness and response. And there's also an interactive report and dashboard that allows visitors to slice and dice the data in a number of ways, as well as a downloadable infographic. As we mentioned before, you're able to request data directly through our website, or you're able to receive data through the ICPSR website, as well as all of our technical documentation and tools that are going to help you understand how to use that data for yourself. And we've included one link at the bottom of this slide, and on that website, there's also a link out to ICPSR's website. I'll move to the next slide. So similar to the 2019 profile, which we've discussed, we have a page on our website that's dedicated to our 2020 Forces of Change survey. That's at NACCHO.org/forces. It includes an in-depth downloadable report, once again, as well as a printable infographic and links to 2 different empirical articles that we have that we've published so far, highlighting analyses from this data set, including local health official harassment, health information technology, behavioral health preparedness. And soon you'll be able to request this data, just like the 2019 profile data, which is at the same length. link, and the 2018 data is also available through ICPSR currently, although we've not highlighted those findings today. Next slide. To close, we would like to, Margaret and I thank you for giving us an opportunity to highlight some of these data today. We're excited to answer any questions that anyone has. Only we want to acknowledge and thank our current core profile team at NACCHO and the research and evaluation departments who have worked for many, many hours and months to make sure that profile and forces of change remain a critical and important and usable data set available to the public to tell us more about local public health departments and provide that information to policymakers, researchers, and the public at large. So we want to take an opportunity. We got done slightly before we thought we would, but I think I can hand it over to Tyler if there are any questions.
Yeah, thank you both so much for this informational presentation. So we have two questions so far. One from one of our guests, Heather Krasna. Here's the question. It's, does the median and mean per capita expenditure decrease translate into pay cuts, reductions in benefits, or are health departments hiring more people at lower or more entry levels who get paid less money while senior level staff retire or quit?
I think this is a great question, Heather. That is one of the few things that we probably can't answer with our data source. So a lot of industries and professions will do things such as compensation and benefits surveys for their field. We've not included those questions in forces of change or in the national profile of local health departments. But to your first question about the per capita expenditure numbers decreasing over time, translating to pay cuts, that's something that I think is a little bit unclear. We might be able to get at some of that if we do some additional analyses, which we'd love to hear from you, because in addition, we accept data requests from the public on our website. One thing I can say about the numbers that we shared today, though, we shared the COVID-19 expenditure data, and we also shared the expenditures over time. Since we don't have that readily coupled today for this presentation, it gives us the ability with this data set to look at those trends next to one another. I know in 2020, for example, we saw that there were net losses in positions at some LHDs, but overall nationwide, there was an increase in the number of staff. So it's certainly something we'd love to look more into for you on this.
Thank you for responding to that. So we don't have any other questions in the chat, but if anyone wants to put one in, feel free to do so. There's quite a few of you here, so if you have any questions at all, please ask away. Okay, we just got another one. Here's the question. So for example, oh, I'm sorry, actually that's something we should answer. It's an ICPSR question, but I'll ask it anyway. So it's, so for example, the National Profile Local Health Department's 2016 data restricted use level is a public data set. So my colleague's going to answer that for that person, but just so you all know, there's a restricted data set and a non-restricted. So some of the data has sensitive information that you have to get access to see and use. But here's another one. This is from Kevin Sevasco. Is there information on LHD specific COVID responses like number, size of public health led testing and vaccination sites?
So we do have a section in our forces of change data that's related to both contact tracing, and we have several questions related to vaccination. That's something that we can get you the full list. We can provide that. There were around 40 questions in our forces of change survey. but two of those did include questions related to vaccination.
Thank you. So I don't know if you all want to hang out for a little and wait for any more questions, or if there's any other comments you'd like to give before we end this webinar. Tim and Margaret. No? Okay.
Thank you for the opportunity.
Thank you.
Thank you both for coming. This was very informational, and I hope a lot of people get a lot of good use out of the data you guys are doing. Well, that's it for this webinar. Thank you all for coming, and thank you all for presenting. I just have to give a quick plug, HMCA. Oh, actually, we have one more. Oh, this is a comment. So someone says the data you have is hair-raising. How did anyone manage to get through the pandemic?
I think the fact that we got a 40% response rate after having this out in the field says something to the dedication of the folks in the field, their interest in having their voices heard, because I know they didn't have time to sit down with this when they were doing everyone else's jobs. But yeah, I think looking forward over the as we continue this survey longitudinally, it will be interesting to see how some of these services that were cut as a result of COVID or diminished, how they recover and in what form that takes. That's what I'm excited for.
Yeah, and that seems really interesting. Well, thanks again. And just real quick, HMCA here at ICPSR, we're going to have another webinar the 23rd of February. So stay tuned for that one. We're going to send out a link for all of you all who came to this one to register for that one if you'd like. But thanks for coming, and thank you guys, Margaret and Tim, for coming as well. And that's it for today.
Thanks.
Thanks, everyone.
Bye.